Hello, everyone, and welcome. My name is Brian Alexander, and I'm the National Sales and Marketing Manager at Starman America. I'd like to start by thanking you for taking the time to join us for this on-demand webinar on biliary radiofrequency ablation using StarMed's ELRA RF catheter. We're excited to be joined by Dr. Jonas Redmond, Associate Professor of Radiology at UC San Diego, who brings extensive experience and insight to the field of minimally invasive hepatobiliary interventions. Today's session will cover a range of topics designed to provide a comprehensive overview of this innovative technology and its clinical use. We'll begin with a clinical background on biliary structures, indications, and patient selection, followed by a device overview of StarMed's ELRA RF catheter and Viva Combo RF generator. Dr. Redmond will then guide us through case videos and procedural techniques, share his institutional experience and outcomes, and we'll briefly touch on reimbursement for those interested in learning more about implementation. Before we begin, I'd like to take a moment to properly introduce Dr. Redmond. Dr. Jonas Redmond is an associate professor of clinical radiology and attending interventional radiologist at the University of California, San Diego Health System. He has been instrumental in developing several new interventional service lines at UCSD, including the Advanced Hepatobiliary Service, which features percutaneous endoscopy and radiofrequency ablation of lesions within the biliary tree. A fellow of the Society of Interventional Radiology, Dr. Redmond has authored numerous peer-reviewed publications and presented at both national and international meetings. As you watch, we encourage you to engage and ask questions. Simply scroll down beneath this video to submit your questions and comments. A follow-up question and answer session will be created to address the topics and questions that come in from this program. With that, let's get started and turn things over to Dr. Redmond to lead us through today's session.
All right, welcome everybody. My name is Jonas Redmond. I'm from UCSD, and I wanted to thank Brian Alexander and the rest of the StarMed team for organizing this. Today we're going to be talking about percutaneous endobiliary radiofrequency ablation. We're going to be focusing more on the malignant side. That's where there's the most evidence, but we're also going to talk about using this for benign strictures as well. So we're going to get right into it. So during this talk, we're going to talk about the epidemiology of malignant and benign biliary strictures and summarize the most recent evidence. And we'll see that there's still some more work to be done, but we'll get to that later. We're also going to summarize the history and rationale for endobiliary RFA and how the temperature-controlled version, which is the ELRA catheter, has been a step up in terms of patient safety and also kind of reliability. We'll also go through the ELRA catheter design settings and step-by-step technique. You'll see that this is a pretty easy additional kind of therapy to add to your toolbox when you're treating various strictures. And we'll also discuss the safety profile, get into some patient selection, and also some practical tips. And then finally, we'll just mention, what is the future of endobiliary RFA? And so to jump into it, we're going to talk about epidemiology. So malignant biliary strictures, depending on where you are in the world, it can be due to various different primary cancers. Pancreatic adenocarcinoma would be the most common in Western countries and most common overall. Cholangiocarcinoma is more common in certain areas, including Southeast Asia, due to liver fluke infections, and also other pockets in the world as well. There's portions of Europe due to higher rates of inflammatory bowel disease and PSC. They have a higher rate of cholangiocarcinoma. Gallbladder carcinoma is more common in areas with endemic gallstones like South America and India. And then other less common causes of malignant biliary obstruction, ampullary carcinoma, metastases, and also a small percent are actually due to HCC. As we know, these strictures are insidious and often present as unresectable disease. Endoscopic management remains first-line option for a lot of these patients. That way they don't have to have one of our biliary drains sticking out of their side. But when that's not an option, then we provide a very meaningful and good second-line option through a biliary drain and then management from there. So the goal of endoscopic or percutaneous intervention is to resolve any of the signs and symptoms related to obstruction. A lot of times they come in cholangitic, and we first have to place a drain and let them cool off, and then figure out what to do from there. We can also aid in treatment by decreasing the bilirubin and allowing them to get various forms of systemic therapy. And then there's also a question, which really hasn't been completely proven, but whether there's some sort of abscopal effect, specifically when it comes to biliary RFA and systemic therapy. And also in general, we want to improve the quality of life for the patient, which really means, if we have a biliary drain in place, hopefully getting rid of that biliary drain and internalizing them in some way. For benign biliary strictures, most of them are post-surgical, especially in Western countries. And the most common procedure it's associated with is laparoscopic cholecystectomy. And just the sheer volume of that procedure, we see that fairly often. For centers such as mine, which is a pretty high volume transplant center, we also see some benign strictures related to post-liver transplant. Other causes, primary sclerosing cholangitis, pancreatitis, choledocholithiasis, especially if the stone has been there for a long time and results in inflammation and stricture of the distal CBD. And then also other more rare ones like IgG4, various inflammatory or traumatic strictures. So again, endoscopic management remains first-line option for these as well. And they can place fully covered self-expanding metal stents and then remove them at a later date. They can also place multiple plastic stents. Usually a single stent isn't enough in terms of diameter to really get the stretch needed to resolve these benign biliary strictures. But when they use multiple stents, that can help. And then percutaneous management, when either endoscopic management has failed, they've had altered surgical anatomy, which makes it difficult for our GI colleagues to get there, or if they're just unable to cross the lesion retrograde. We know that getting access to the biliary tree and crossing antegrade, we're usually successful, if not the first time, then the second time. So it remains a really good option. Goals of the intervention are to restore unobstructed flow through the biliary tree. This is both for symptom relief and also if it's a transplant, especially to preserve liver function. And then also we want to minimize tube dwell time. And again, that's where biliary RFA has come into the picture. So to summarize the evidence for use of endobiliary RFA for malignant obstruction, first of all, we're going to dive into overall survival. And this is actually the one that has the most evidence behind it. So out there, the literature supports a survival advantage for RFA plus stenting over stenting alone. And it's not always consistent with stent patency, meaning that's why people think that this may be secondary to an abscopal type phenomenon. But that is still yet to be really proven. This has been included in the American College of Gastroenterology and their guidelines. So for it to be included in those, it's got some good evidence behind it, and it is really the one thing we can really hang our hat on. So various studies have been published over the years. The one thing that you can notice here is that there has been benefit from plastic stents when it's used with RFA, also with self-expanding stents. So it's pretty heterogeneous, but overall, this signal that improves overall survival is there, and is the most reliable of all the potential benefits of RFA. When it comes to quality of life, it's less clear. There's just really sparse data. People are really looking at other things like patency and also overall survival. But there are some studies out there that have looked at some quality of life. This Karnofsky performance scale is anybody with above a 70 basically has some pretty meaningful independence in their life, and so this study actually showed that there's a benefit to RFA plus stent as compared to stent alone when it comes to this performance score, and that was up to 9 months post intervention. So highlighted in yellow is that one study I just mentioned, and then you can see that other studies maybe looked at it peripherally, but there really hasn't been really some high quality studies to look at this. And then when it comes to stent patency, although there is kind of a signal towards that it does improve stent patency, that is not across the board. And so to say that it definitely does, this is one area where you can look at various randomized controlled trials that have shown that there is a benefit or there isn't a benefit. But more studies have shown that there is a benefit, although more recent studies, including randomized control studies, have not shown that. And so this is just one of those studies that shows, again, like I mentioned before, it may improve survival, but it does not significantly impact stent patency. And this was recently published, I think, in 2025. So here you can see, this is a very busy slide, but it does show that that it is kind of mixed results. The ones highlighted in yellow, you can see there are meta-analyses of randomized controlled trials, including other randomized controlled trials that have shown no significant difference. Other studies have shown that there is a benefit in terms of stent patency. So again, a lot more studies out there that have shown a benefit, but it is not uniform. So in summary, for the evidence for malignant biliary obstruction, most recent publications support the claim of improved overall survival, which is consistent with the gastroenterology guidelines. Quality of life and stent patency is less clear. This is something that we can focus on moving forward with any future papers, especially if we're starting to publish more here in interventional radiology. That's going to become really important. But there is at least a signal towards improved patency, and at least one paper that shows some improvement in functional status. Keep in mind that a lot of these studies, are pretty heterogeneous, but in general, people are using uncovered stents for more hilar obstruction and covered or partially covered stents for distal obstructions, although people still are using bare metal stents for distal obstructions. And there really hasn't been a clear right answer when it comes to that as well, but that's a topic for a different talk. So again, barriers to clear answers, heterogeneity of the disease process, the patients, and what's being used. I mean, these studies have been published mostly in the GI literature. So it'd be beneficial for us in IR to publish more of these papers. And when it comes to GI, they use a mix of plastic stents, fully covered stents, bare metal stents, all sorts of stuff. Also, these patients are very sick. They have, a shorter lifespan in general. And also this, when it comes to research that's out there, this isn't PE, this isn't Y90. So it's not like there's a whole bunch of money out there and a whole bunch of people who are publishing on this. But those of us that do this very often know that the impact you can have on somebody's quality of life when it comes to these biliary procedures is significant. And if you can get somebody tube free or and fix their stricture, they're very happy to have that biliary drain out, and are very happy with you that they can go swimming, have less worry that their drain is going to get caught on something, that kind of thing. So although still a very significant improvement in patient lives, it doesn't have all the funding, and it doesn't have the number of research papers that are out there that are really driving this forward. All right, so when it comes to benign biliary strictures, this is something that's a little bit newer, and is something that, for anybody who follows whatever benign biliary stricture that you use at your institution, that these protocols are at least 6 months, a year. And if we can shorten that dwell time in somebody who is has a liver transplant and is otherwise doing well but has this benign stricture, if we can shorten that time so they don't have a biliary drain for over a year, that's going to be a significant quality of life improvement. So limited data out there so far. I mentioned that. These are the three kind of best studies that I've seen so far, and we're going to focus on the one that's out of Northwestern here. So not a huge number of patients, 15, but they basically did just about one RFA procedure per patient, and it was technically successful in 100%. Clinical success rate really high, 87%. That's higher than some of the benign stricture protocols out there. And then really the benefit here is the 1-year patency rate after treating these patients with this new protocol is 100%, and very low complication rates. And you can look at the IR visits pre and post RFA. It goes from 8 with a range from 1 to 51 to 1 with a range of 0 to 9 in terms of initial follow-ups. So all this, and then drain insertion, the same thing. All this is pointing to the same thing, which is if you are able to get these people in and they're an appropriate candidate for RFA, then you can significantly reduce the number of times they need to visit IR, the number of times they need to have their drain exchanged, dwell time for their drain. And if you decrease all that, the quality of life for these patients goes way up. So in summary, there's limited data out there, but it is encouraging. We need to publish more. We have our own data here at UCSD, which is similar to that presented by the Northwestern group. We are still gathering more and more patients. We're about at the same level right now with about 15 that have up to a year and a half follow-up. But we'll have to dive into the actual numbers and get that published in the future. But the signs we're seeing here are also encouraging. So look forward to publishing that in the future. But yeah, we need more data. And as we move on, new devices, refining our techniques may improve these numbers even further. But the bottom line here is like so many other things in IR, we want to try to get these tubes out of patients as fast as possible, while still being very, very successful when we do remove those tubes, that they don't need to bounce back to us. When it comes to the ELRA catheter itself, we're going to jump into to all the details and also the technique. So it's a 7 French catheter, which is, very reasonable size for pretty much any biliary intervention. The smallest biliary drain I typically place in people is a 10.2 French. But I try to even start out when I first place the biliary drain. If it's more like 12 or 14 French, I think that's a better starting spot for people. There's less clogging of the drains, and I think it does a better job of decompressing them. But the ELRA catheter is bipolar. It's so there's no grounding pad that you need to put on the patient's leg. It's temperature controlled, which is the main difference between other RFA catheters. And it has automatic power modulation. That means that when you set it at 80 degrees C, which is the typical setting for it, it's going to keep it right around that temperature, and it's not going to let it go super, super high. One of the other benefits is the short shaft length of it. It's 40 centimeters, but the electrode lengths are also variable. So you can choose an electrode length that matches the stricture the best. And I'll show a little bit more about that. So, excuse me. Again, the ELRA catheter is temperature controlled. When you compare it to non-temperature controlled catheters and the evidence that's out there, there hasn't been any reports of bowel perforation and decreased risk of any hemophilia. It's a more predictable ablation because it is temperature controlled, and so it's not going to skyrocket depending on the consistency of the tissue, and so that makes it a little safer, as we know that there are arteries that can be close by to where you're ablating, and other structures as well. So the multiple ablation lengths, like I mentioned, is a real benefit, and then also when compared to just one ablation length, that allows you to tailor it a little bit better. And we know that if you are able to ablate a stricture with one round of ablation instead of doing a bunch of overlapping ablations, that also tends to mean it's a safer ablation with less variables. So when we talk about the catheter name, what's on the box, and the ablation zone, you should be aware that the catheter name, so it comes in 11, 18, 22, and 33 millimeter lengths, is different than the actual ablation zone. And you can see that on the bottom side of these catheters. So an 11 millimeter catheter has about an 8 millimeter ablation zone, and so on down the line. And you can also see that depending on the arrangement and size of the electrodes, it also penetrates into the tissues a varying amount. So the 22 millimeter catheter actually has the deepest penetration into the surrounding tissues. And that's something to be aware of because you're going to want to use that in an area that that maybe is a little bit safer for that higher power. And that's more like distal CBD and like a big, malignant obstruction due to pancreatic cancer or something like that. And that's true for the 33 as well. For me in my practice so far, the most common size that I use is the 18, and I've used that for both benign and malignant strictures. You can also use, if it's a really focal stricture, that 11 millimeter one is really nice too. So this is just an example of what before and after RFA can look like. Sometimes you don't see that quite that dark of an ablation zone. Sometimes it looks like a pale white or gray, but you can definitely tell that after ablation, especially if you use a percutaneous endoscope, like I use a lot of the time, you can take pictures before and after, and you can really see a difference. I'll show some of that later. So this is a video of just the device. Obviously, this is on just a piece of pork, but you can see it when it's activated. You can see that the ablation zone forms between the two electrodes, and you can see how it rapidly tapers off, which is why the actual ablation zone is slightly shorter than what is the name of the catheter. And so as it goes on, it's going to keep it about that same size. And so we're going to move on. That's a whole 2-minute video. And so it just gives you an idea of what the ablation zone looks like. So technique is pretty easy. It's standard, catheter wire technique, something we do so many times every single day. Here, though, the most important part, besides getting your wire past the stricture or the occlusion, is making sure you have good pictures, whether you're using cholangiography or cholangioscopy or both, to make sure that your II is angled the correct way, and so you really know that you're not ablating too far back up into the biliary tree, too far into bowel, but yet you're getting a good treatment across that stricture. The settings are pretty easy. It's you set it on temperature mode, and anybody who does thyroid ablation, you're setting that to continuance, which is a different setting on the same generator. So it's nice if you're also doing thyroid ablation that you can just plug in this biliary catheter to that same generator, change the settings a little bit, which takes a couple seconds, and then just go from there. But in general, it's 80 degrees C, and then depending on the catheter size, and you can see that in the prior image that I provided, it's either 7 or 10 watts, and the typical ablation time is 2 minutes. So after the ablation, sometimes you stir up a little blood. There's some oozing, there's some clot that forms. You can do some gentle balloon sweeps. If I'm going to be stenting, then I'll typically just do a couple balloon sweeps and then place the stent. If it's a benign stricture, then I'll typically balloon it up before place a big catheter across, and we'll talk more about that as well. So again, just to mention, self-expanding metal stents here can be uncovered for distal CBD. It can be uncovered for hilar, and then for distal CBD, there's really no wrong answer, although I think a lot of us are using covered or least partially covered stents for malignant obstruction. So again, just looking at the console, this is how it's set up. So you can change the mode to temperature mode, and then use the dial to change everything to the correct wattage and temperature. So there it says temperature mode, and then do these settings. So right now the temperature is at 75. I would change that to 80, and then just click through, and then it will tell you that it's ready. Once it's ready, there's a foot pedal you can use, or you can also have one of your techs just press this button, and then that's it. You start your 2-minute ablation. Once it's finished, you just take it off over the wire and continue on with the procedure. So for, like I started to mention before, some of the things I've noticed is for distal malignant bowel obstruction, I still use the 18 a bunch of times, although you might need to go to a longer size. And this is where, that 22 or that 33 can be helpful. For highway lesions, because I'm trying not to burn across biliary radicals, I try to use a shorter electrode, and that's been working out pretty well so far. I haven't had any issues where, I've caused like just an isolated duct from my ablation. And so it's just something to be aware of. And another reason why you need really good pictures, really good cholangiogram before you do this. And then you're never going to get away with just RFA, especially for malignant bowel obstruction, right? This is just to help with kind of beat back the tumor. And if you're using an uncovered stent, you'll have more time before it starts growing through the interstices of the stent. And also there's, the studies that have shown there is a survival advantage when you use RFA plus a stent for malignant obstruction. Whenever possible, and sometimes it's impossible if there's tumor already invading the area, you try not to ablate across cystic duct takeoff or pancreatic duct. Also, so for recent anastomoses, strictures take time, thankfully, after surgery to really form. But if you have somebody who, was really just kind of sewn too tight, and it's within, we use 4 weeks. But, if it's earlier than 4 weeks, I think it's more of a conversation with the surgeon in terms of reoperation than it really is pushing the limits of, burning across a fresh anastomosis. All right, so complications. Thankfully, these are pretty rare. You can get some hemophilia. It's self-limited. I've never had any sort of situation where I've had to embolize anything after this procedure. Obviously, cholangitis is always a consideration whenever you're dealing with biliary drains, and perforation really is rare, and that was really shown with or rare, and it was only really seen with the non-temperature controlled devices. And then you can also get pancreatitis, but that's more from the GI side than it is from our side, although it can happen rarely from an IR percutaneous approach. So risk reducers, again, temperature control, everything that we have in terms of evidence so far seems to point towards this ELRA catheter having a better safety profile, and just being smart about which catheters that you're using where. So shorter electrodes at the hilum, avoiding overlapping ablations, and making sure that you stent for malignant biliary obstruction. Again, you're not going to get away with just RFA. So here are some cases. This is a 59-year-old male with a history of pancreatic adenocarcinoma. He's status post Whipple, now with recurrence at the anastomosis and resultant malignant bowel obstruction. He had a single left-sided biliary drain initially placed. We always have that conversation with the surgical team just to get them to sign off and make sure this patient is not a surgical candidate, which they did. And this is what the initial MR looked like, and you can see just what you would typically see with a distal obstruction, just diffuse dilation of the biliary ducts. This was the left-sided drain that was initially placed, and then when they came back for the procedure, you can see that it's almost right over the pedicle. right-sided pedicle, but you can see there's a stricture there, which we then measured. And so for this, we used 18, so we used just a couple millimeters outside of the 11 to 12 millimeter measurement that we had. And this is a slightly different angulation, but you can see that the 4 electrodes and the ablation zone is going to be centered kind of starting maybe halfway between the 2 electrodes on the end and extending through the other 2 in the middle. So it was a 2-minute ablation, and then we placed a partially covered stent here, and that was because we knew we were going to get close to the hilum, but everything has been draining really well since that time. The stent was placed back in March, and this patient has not bounced back to us, and that's what we would expect. And then the second case, this is a 65-year-old man with hilar cholangiocarcinoma and resultant obstruction. And so he originally presented with cholangitis, and we placed bilateral 10 French drains, let him cool off a little bit, finished his course of antibiotics. And again, not a surgical candidate. So then he came to us. This is just his CT showing his cholangiocarcinoma centrally. And this is our cholangiogram showing bilateral, typical Klatskin tumor type appearance, bilateral obstruction. And here we use the catheter first on one side and then on the other. And then use some balloons, just stretch everything open, place some stents. And this is a video just showing, how you can use cholangioscopy. And this is here. I'll move this forward. So this is me looking from one side as we're treating the opposite side with the ELRA catheter, just making sure that the electrodes are where I think they are in terms of relationship to the hilum and the tumor. And you can see as we turn it on, it immediately starts to create bubbles and really just kind of almost smoke out our image. But that allowed us to see in a different way, in addition to our diagnostic cholangiograms, where we are and what we're doing. All right, now for a benign case. 72-year-old with a history of HCC. He was treated for his HCC and got a liver transplant, and then it was complicated by a biliary and anastomotic stricture, which was then revised about a year after his transplant, and now he comes back again with recurrent biliary obstruction and repeated bouts of cholangitis. So nobody wants to jump back into this guy after a full-on liver transplant and then redo of his anastomosis. So they asked us if we could do anything. Of course, we said yes. This is the MR showing a short stricture right at the anastomosis with the bowel. And then initially, one of my partners got an external biliary drain in but could not cross. And again, this is where the combination of having a scope and also the biliary RFA is really helpful, because I was able to get in there, and as I started looking around to try to figure out a way to cross with a wire, I saw these small little air bubbles coming up from the bowel. It allowed me to target that area with a wire and then cross and place an internal external drain. At this point in time, when he came in for this part of everything, he was still had a simmering infection, so we just chose to cross him and let him cool off a little bit more. Brought him back about 10 days, 14 days later, and then measured the stricture. Again, used the 18 millimeter RF catheter, centered it across the stricture. And then this is post, like I mentioned before, it's not always the kind of grayish, blackish char that you see. Sometimes it's a more gray or white. It also depends on the white balance of your scope that you're using. But then we placed an 18 French drain across that, brought him back. Our protocol is to bring him back 4 to 6 weeks later, and then we do an over-the-wire cholangiogram, And if everything looks good, we externalize him, have him get labs in about a week. And then about 10 days, assuming the labs look good and he's been tolerated being capped with this external drain, we can just bring him back in, take one more picture, and pull it out. So procedural tips, antibiotic prophylaxis, is what we would typically use for your biliary procedures. If you have a really extended, difficult procedure, you can choose to extend the antibiotics for those procedures, giving them about a week-long course of whether it's a fluoroquinolone or augmentin or something like that. Those are typical antibiotics to use in that case. So sedation wise, I know some people have gotten away, and I've gotten away with using moderate sedation for these, but whenever possible, I use a MAC because there have been times when I have actually had patients kind of start kind of moving around on the table because they're uncomfortable when there's moderate sedation. And like I said before, it's all about planning. So you measure the stricture as precisely as possible. And that means your image intensifier might be in some weird angulation, but take the time to get that right. Cholangioscopy is beneficial just to take a look at everything, both pre and post. And you can also get an idea of stricture length using your cholangioscope. So if you have it available, it's a good adjunct to use. And then, you just choose your electrode length accordingly. And like I said and explained before, the ablation is actually pretty straightforward. After your RFA, it might look like it's actually worse unless you do some sweeps because you might have caused some clot to form, and you can get rid of that. And then from there, if it's a malignant obstruction, you're going to stent. And for benign strictures, you should be using, in my opinion, and other people out there that have been doing similar procedures are typically aiming for at least an 18 French catheter after you RFA to let the stricture kind of heal around this bigger tube. Quick note just on billing and reimbursement. The CPT code that we've been using is this unlisted procedure biliary tract 47999. That carries with it here, at least in Southern California, work RVUs of about 3.3 and total RVUs, it's actually like just above 5, but essentially 5. Again, in this area, we're getting about $80 per RVU, which then translates to this being about $4,000 for the hospital. And so I think this is pretty reasonable, pretty quick way to get a boost in RVUs in addition to all the patient benefits and stuff like that. It's a pretty quick way. 5 RVUs for something that takes essentially 3 minutes is pretty decent. So who may benefit in the end? Well, lots of people with malignant bowel obstruction. We're looking to use this whenever possible. We're studying the CT or MRI before we do any sort of RFA to make sure there's not just some huge artery right next door. If that's the case, then we may shy away from it. But most people who have a malignant bowel obstruction who you're planning to stent, you should at least strongly consider using RFA for at least a survival benefit. But as time goes on, I'll be curious to see if there is also a patency benefit and quality of life benefit as well. So for benign strictures, refractory or to standard management, or especially those that aren't surgical candidates, go for the low-hanging fruit here. When we first started doing this, our surgeons were rightly skeptical, especially if they did the anastomosis. And now that anastomosis might be a little bit tight, they are protective of their work. And it took a lot of discussion with them and showing them the evidence that's out there so far, and just pick really easy short strictures at first. That'll be a pretty good recipe for success, and then you can move on from there. And of course, you want to be safe with these patients, so avoid those patients who have active cholangitis. You want to let them cool off first. Recent anastomosis, like I said, we use 4 weeks. I think that's pretty standard. And then, if there's a fistula or perforation, you should let that heal first before you start going after any sort of RF of any stricture or anything like that. So where are we? Well, it's kind of the same place we've been with various procedures. The evidence that's out there, I think favors using RFA more often, but you could take the evidence that's out there and use it either way. For a while, I know some places were jumping on the bandwagon to start doing pulmonary thrombectomies. Other people were saying no, the evidence isn't there. So we've been in similar places before, and it's really kind of how aggressive you want to be, and in discussion with your surgeons and the rest of your team, if everybody's on board, then I would encourage just moving forward with it and getting comfortable with it, because I think as time moves on, we're going to see more and more studies coming out that show significant benefit to using RFA. Look out for some upcoming randomized controlled trials. The Attica 2 from Europe is a randomized controlled trial, and it's going to use 120 patients with perihilar ductal cholangiocarcinoma, and they're going to be randomized to RFA plus bile duct stenting versus stenting alone. And so that should be a really good trial that we should see results in about 1 to 2 years. And a similar trial is happening here in the USA. It doesn't have a name quite yet, but there is some stuff in the works to keep an eye out for. And then we do need this high quality research to give us, hopefully a clearer direction of either certain patient subsets to use RFA on, or give us some more clear guidelines. And for benign strictures, this is something, again, we all have those patients that come back every 2-3 months for biliary tube changes and stuff like that. So I think there's going to be more and higher quality studies with more patients than the 15 that was included in that Northwestern study, and hopefully that points us in the correct direction to know which patients to use this on, or whether it's based on stricture length or whatever. But I expect those to be coming out as time goes on, including hopefully a paper from us sometime in the near future. And then whenever anything works, my next question is, where else can I use it? And so we'll see. My current conversations with urology and for neobladders and ureteral strictures related to anastomoses in that setting. But thinking about those kinds of things, there's no cases that have been done yet or anything like that. But thinking about all these patients who have tubes for various reasons, if we can utilize RFA or something else to decrease their dwell time and get their tubes out, we're going to have a lot more happier patients in our practices. So in conclusion, there's a lot of promise here. We still need more evidence to really prove that it works, and prove that it works for various different aspects, whether it's patency, quality of life, etc. And the temperature controlled nature of the ELRA catheter seems to be a benefit over competitors. Absolutes are not really possible right now, but if we can clean up the murkiness present in the current literature via our own randomized control studies or high quality studies, that would be great for IR and great for our patients. And then, the cancer drugs that we're using or that our oncologists are using change so rapidly. But if we can find, some clarity on what regimens are working well, what regimens may have, some sort of abscopal effect, if there really is one there, that would be, again, a benefit. And then also, our industry partners who are making these catheters and various new devices, need to continue to partner with them, and hopefully there's improvements both on the technical side of things, and as we move on, our expertise in how we're evaluating these patients and using these devices. Thanks a lot for your attention. I'm definitely going to be available for any questions, and I believe Brian told you how to get in touch with me, and I will be sure to answer all those questions as soon as I can. Thanks again for your attention. All right, well, thanks everybody again for attending the webinar, and right now we're going to get to some questions that people submitted. I'm going to read out each question and then answer each one. So the first one is, for someone using the ELRA catheter for the first time, what would you consider the ideal starter case in terms of pathology, stricture length, and anatomic location? So I think good starter cases could be malignant or benign. For malignant obstruction, definitely distal CBD. You don't want to start with a Hyler case or anything like that. So the cleanest case would be distal CBD, not involving the cystic duct or extending up to the hilum, and knowing that you're going to ablate and then stent. That would be an ideal malignant first case. For benign, really the shorter strictures are easier to treat. So something less than a centimeter in terms of stricture length, and at least 1 month out from surgery. You don't want to ablate a recent surgical anastomosis. But those would be the two best starter cases. Second question is, what complication or technical mistake do you see most frequently, and how can it be avoided? We haven't had any major complications when we've been using this catheter. I think some post-procedure pain. We haven't had anybody go septic from a procedure like this, although technically those are all possibilities. So no real complications. Technically, I would say that you have to make sure you spend some time profiling the stricture, especially in benign cases, so that you know exactly how long it is and get the correct ablation length for your catheter, and then also center it appropriately. And besides that, it's a pretty straightforward tool to add to kind of your biliary cases. The next question is, what is your preferred approach to guide wire management during RFA? Do you ablate over the wire, partially withdraw it, or change wire type to avoid thermal conduction? So yeah, the ELRA catheter is designed to be used over a guide wire. I typically use an Amplatz. I haven't seen any complications such as perforation or anything like that, but I still assume it might happen. So therefore, I want to maintain wire access kind of across the region I'm ablating. Next question is, based on your experience, what does the learning curve look like for IRs adopting percutaneous biliary RFA, both technically and in terms of case selection? So it's pretty easy aspect to add to any biliary case. Like I said, taking the steps necessary to make sure that you're profiling the area you're going to treat, choosing those distal CBD cases at first, and then moving on from there. The ablation adds minimal time; it's 2 minutes, so it's actually pretty easy to do, and I've shown it to multiple of my partners. Really, it takes maybe 1 or 2 cases. The other thing that we do is we have a laminated card on the side of the generator. That's just to remind everyone who's involved in the setup what the appropriate settings for the generator are, so that everybody's on the same page, because techs come and go and stuff like that, and even if it's a new tech, it's really easy to set up the machine and then set up all the parameters and just go. Next question. In malignant biliary strictures, do you typically extend the ablation slightly beyond the stricture length, or do you limit treatment strictly to the defined segment? So I go just maybe a couple millimeters beyond the stricture. This isn't the same 5 to 10 millimeter margins that we do for like liver microwave ablation or something like that. But I do want to make sure I get the entire length of the stricture. So I do go maybe, just a couple millimeters beyond it. Next question is for higher lesions. Do you recommend sticking to the you recommended sticking to the 11 or 18 millimeter electrodes? How do you position the catheter to avoid thermal injury to the contralateral hepatic ducts across the bifurcation? So a lot of times, if we're treating that area, these highlight tumors involve both ducts, and so I know I'm going to ablate both sides anyway. But if I don't have to ablate both sides, both of those electrodes will keep the penetration depth to the minimum, and so far I haven't seen any issues ablating one side with those electrodes. The standard settings are 80 degrees C at 7 to 10 watts for 120 seconds. Under what circumstances do you modify these parameters? For example, in benign disease, prior radiation, or near surgical anastomoses. So far I have not modified the settings at all. I choose the whatever catheter length, ablation length I want, and set it just for the standard settings. And so far, again, I haven't had any major complications. And that includes across benign strictures at surgical anastomoses, et cetera. All right, the next question is, for strictures that span multiple segments, how do you determine whether to perform a continuous ablation or separate overlapping treatments? I assume by continuous ablation, you mean just ablating in one solid, even though it's stepwise, in one kind of big ablation zone. So it's designed to be used in a stepwise fashion. So you ablate a segment and then you can move it and ablate another segment. I keep the amount of overlap to a minimum. There has been some cases with biliary RFA catheters where there's been some complications from ablating the same place twice. So I keep that overlap to a minimum. But if there are multiple separate segments there's some normal biliary tree in between, I don't just treat the entire thing. I would choose the segment that's diseased and then move to the next segment that's diseased. I hope that answers that question. Next question is, you recommended a balloon sweep post-ablation to remove debris. If a stent will be placed immediately afterward, is the sweep still necessary? It's not always necessary. I tend to want pictures immediately before I stent. And so if I do an ablation, I want to do another set of pictures or images before I place the stent. And if it's kind of muddied because there's some blood that got mixed in there and it's not going to flow through the area of stenosis, or it looks a little bit different, I'll sweep it just to make sure I have a clear picture of what everything looks like. Also, even though I haven't seen this yet, I also want to make sure that if there is something like a perforation or a leak, I see it and know it's there. So far I haven't seen that, but that's the other reason, just to kind of clear the area so you get good pictures and make sure there's no complications. All right, next question is, if a ductal perforation or segmental duct injury occurs during RFA, what immediate and follow-up management strategies do you recommend? So, if there was a perforation, similar to the way we would treat any sort of biliary leak from, cholecystectomy going bad, it would be similar to that. Place a biliary drain across it, probably bring them back in about 4 to 6 weeks. And that's the same for any sort of biliary injury. I think the treatment would be to get a tube across and then let it heal for a period of time and then bring it back and do an over-the-wire cholangiogram and go from there. Next question is, do you modify your biliary RFA approach in patients actively receiving chemotherapy or immunotherapy? If so, does this influence when you schedule the procedure? So in general, I don't. This is still really, it's an extra step to what is otherwise usually a biliary drain change. However, if in conversation with the patient, they tell me that they feel particularly horrible after their systemic therapy, or if if their counts drop really low from systemic therapy to the point where they're at increased risk for complications like infectious complications, then absolutely I would change the timing. But in general, we don't have like a protocol that says for anybody on systemic therapy, you need to separate it by X amount of days or weeks. The next question is, during biliary RFA, which ductal configurations or anatomic locations do you find the most prone to thermal injury, and what technique adjustments help reduce this risk? So again, I haven't seen any major complications from the patients I've treated in terms of ablating across a duct that then becomes obstructed from the ablation or anything like that. But those are the situations where I would be extra careful. I try not to ablate across any other ducts, and I've used the standard settings each and every time. It's if I'm a little bit worried about a space that I have, then I'll choose a shorter ablation probe, make sure that I know the depth of penetration of that ablation, and just find the catheter that matches it the best. Next question is, for benign strictures, you mentioned the goal is tube independence. How do you decide whether to downsize, remove, or maintain an external biliary drain following RFA? All right, so our typical protocol is that immediately after RFA, we'll place an 18 French internal external biliary drain. Bring them back in about 4 to 6 weeks for an over-the-wire cholangiogram. At this point, there's a subjective decision of whether the flow through the strictured segment looks good enough that we think we can convert them to an external biliary drain, or if we think we just need to replace the 18 French drain and give them more time. If we place an external biliary drain, which is usually we place like a 10 French Dawson-Mueller, then we would repeat LFTs in about 3 to 5 days, and we would cap them before that. We'd cap them like the next day after the procedure, repeat the LFTs in about 3 to 5 days, and then bring them back in about 10 days to 2 weeks, and we'll get another set of labs the day of what is hopefully their last procedure. And so if their labs still look good on that day, we'll do a cholangiogram through the external biliary drain. And again, if everything looks like it's flowing through okay, we'll remove the biliary drain. All right, and the last question is, in patients with a hepatocojejunal anastomosis, where a surgical clip is adjacent to the stricture, is RFA still safe, or does clip proximity significantly increase the risk of localized overheating or anastomotic injury? I think, there's not any sort of paper out there that is going to really give us an answer to this question. I think there should be some caution, especially if that clip is also adjacent to a major like hepatic artery or something like that, or major artery. That would give me some pause. Otherwise, there's typically so much scar tissue in the area that I wouldn't worry too much about heating the clip as well. I mean, there hasn't been like a complete disruption of a surgical anastomosis or anything like that. So I think I would discuss it with the patient, say, hey, you have a surgical clip right next to where we want to ablate. Although we don't have a good idea of like what the increased risk would be, because we don't have any papers that really tell us that. Just common sense, there would be somewhat of an increased risk because the ablation zone is going to be extended some. And so after that discussion, unless they were really hesitant to move forward, I would probably move forward and do it. If there is a small leak, which I haven't seen yet, but I think the treatment would be having the biliary drain in place. It would probably heal up, and I don't know if it would really make that much of a difference if it was just a small leak. Yeah, tough question to answer though. Anyway, I hope I answered all those questions to your satisfaction. You can always reach out to me. I'm happy to talk to anybody over the phone. If you want more information, you can reach out through the StarMed team and they can get in touch with me. All right, everybody. Have a good day.